Dr. Adrian Keller stepped into the operating room, knowing the patient's life depended on him. But what no one realized was that this emergency surgery would tear open a hidden network, connecting him to Lina Cruz and Maribel Santos in ways the hospital was never meant to see. Dr. Adrian Keller was known across Chicago as one of the most skilled cardiac surgeons at St. Mark's Medical Center. His reputation had been built over years of high-pressure surgeries where patients with almost no chance of survival left the operating room alive. Colleagues described him as precise, controlled, and almost emotionally detached when working. Outside the hospital, he lived in a quiet apartment on the northern edge of the city, where neighbors rarely saw him coming or going. To most people, he appeared completely dedicated to medicine, with no visible personal distractions. But the life he presented was only one layer of a carefully constructed reality. Behind closed doors, Dr. Keller maintained a hid system that separated his personal world into strict segments. He had created routines that allowed him to move between different parts of his life without overlap or suspicion. Every detail of his schedule was calculated, from shift timing at the hospital to private hours he kept away from public view. This control gave him the confidence that nothing could disturb the balance he had built. Within this hidden structure, two nurses played a central role. Lina Cruz worked in the intensive care unit, where patients fought for their lives after major surgeries. She was known for her calm presence and strong commitment to her work. Maribel Santos worked in the surgical recovery ward, where patients slowly regained awareness after procedures. Both women respected Dr. Keller professionally and trusted his guidance without question. What neither of them knew was that their personal connection to him overlapped in ways that were carefully hidden. Dr. Keller maintained separate emotional bonds with both nurses, ensuring that their paths rarely crossed in meaningful ways. He used hospital schedules, shift changes, and medical urgency as tools to manage distance between them. Small adjustments in timing and assignments kept his secret intact. To outside observers, these changes looked like normal hospital decisions, part of the constant pressure in a busy surgical environment. However, beneath this controlled system, small cracks had already started forming. Minor scheduling conflicts began to appear in hospital records. Occasional inconsistencies in shift coverage created confusion among staff. These details were too small at first to raise alarms, but they marked the beginning of instability in the structure Dr. Keller depended on. Unaware of the growing risk, he continued his routine with the same discipline that had protected him for years. Yet the careful balance he maintained was becoming harder to sustain, and the smallest disruption in the hospital environment had the potential to expose everything he had worked to keep hidden. Lina Cruz and Maribel Santos worked in different parts of St. Mark's Medical Center, which made it easy for Dr. Adrian Keller to maintain distance between them. Lina spent most of her shifts in the intensive care unit, surrounded by patients who were in critical condition after surgery. Her work required constant attention, fast reactions, and emotional strength. Maribel, on the other hand, worked in the surgical recovery ward, where patients slowly woke up after procedures and were monitored for stability. Their responsibilities rarely overlapped, and their routines followed separate rhythms inside the same hospital system. At first, everything appeared normal. Dr. Keller interacted with both nurses in a professional manner during official duties, but his behavior outside formal settings began to create subtle patterns. He would request assistance from Lina during specific 1CU cases, then later appear in recovery situations where Maribel was assigned. These interactions were not unusual on their own, but over time they formed a repeated structure that only he seemed to control. Both nurses started noticing similar details without realizing they were connected. Lina observed that Dr. Keller often appeared near her unit during moments when he was not officially scheduled to be there. Maribel noticed that he sometimes seemed aware of recovery updates before they were formally shared through hospital systems. These small irregularities created a quiet sense of confusion, but neither nurse initially questioned them deeply. Hospital life was fast and demanding, leaving little time to compare experiences. Shift rotations changed constantly, emergencies disrupted plans, and staff shortages forced frequent adjustments. Within this environment, Dr. Keller's carefully managed movements blended into the natural chaos of the hospital. His actions were hidden inside systems that already felt unpredictable. The structure he relied on was becoming more fragile. Internal scheduling logs began showing overlapping adjustments that did not match standard procedures. Some changes were made too late to follow normal approval channels. Other assignments appeared to bypass routine coordination between departments. These inconsistencies were small individually, but together they formed a pattern that hinted at deliberate control rather than random error. Lena and Maribel remained unaware of each other's indirect connection to Dr. Keller, but the tension in the system around them continued to grow. Each interaction he had with them added another layer to a structure that was becoming increasingly difficult to maintain. What once seemed like routine hospital complexity was slowly turning into something more calculated, and the stability of his hidden life was beginning to weaken without anyone fully recognizing it yet. The situation inside St. Mark's Medical Center changed sharply when a critical arrived late in the afternoon. A middle-aged patient was brought in after a sudden cardiac collapse. The condition was unstable, and every minute carried serious risk. Dr. Adrian Keller was immediately assigned as lead surgeon due to his experience with complex heart procedures. The hospital activated full emergency protocols, and multiple departments were pulled into coordinated action. Lena Cruz was called from the intensive care unit to prepare post-operative support systems, even though the surgery had not yet begun. At the same time, Maribel Santos was assigned to the recovery ward team that would be responsible for immediate stabilization after the operation. This meant both nurses were now connected to the same case, even though they had never been formally placed together before. Dr. Keller moved through the preparation phase with his usual precision, but the internal flow of communication around him started showing unusual strain. Equipment requests were repeated through different channels. Medication confirmations arrived with slight delays. Staff members noticed that instructions sometimes changed within short intervals, creating confusion about final decisions. These disruptions were subtle but unusual for a surgeon of his experience. As the operation began, the atmosphere in the surgical room became increasingly tense. The patient's condition fluctuated in unpredictable ways, forcing rapid adjustments. The medical team focused entirely on stabilizing the heart function, but behind the clinical urgency, coordination problems continued to appear. Some instructions seemed to reach staff indirectly instead of through standard procedure lines, causing brief hesitation during critical moments. Lena and Maribel were positioned in different zones of the surgical support system, yet both began noticing inconsistencies in how tasks were being assigned. The workflow did not match the usual structure of emergency surgery. Requests appeared to overlap in ways that suggested parallel planning rather than a single coordinated command. These irregularities created silent confusion among the team, although no one could fully explain the source. Dr. Keller maintained control on the surface, but the complexity of managing both the surgery and the hidden structure around his personal connections placed him under increasing pressure. The system he had built to separate different parts of his life was now operating in the same space, under the same emergency conditions. As the procedure continued, the stability of that separation began to weaken. Small gaps between communication lines widened, and unnoticed overlaps in scheduling and instructions started to surface. What had once been carefully divided was now forced into a single environment, where every action carried the risk of revealing connections that were never meant to meet. As the emergency surgery progressed, the patient's condition reached a dangerous point. For several minutes, the heart function dropped to unstable levels, forcing the team to act under extreme pressure. Additional staff were rushed into the operating room, and emergency protocols were fully activated. The focus was entirely on saving the patient, but the internal organization of the hospital system began to break under the weight of overlapping decisions. Once the situation was stabilized, even slightly, attention shifted to reviewing what had gone wrong during the procedure. Senior administrators and surgical supervisors began examining the communication logs, medication timing, and staff assignments. What they found did not match the standard structure of an emergency operation. There were inconsistencies in shift coordination, repeated last-minute changes, and unclear authorization paths for certain instructions. Dr. Adrian Keller's role became the center of attention. His control over scheduling adjustments was more extensive than expected for a surgeon in his position. CVRAL changes to staff assignments had been made outside normal approval channels. Some of these adjustments directly involved Lena Cruz and Maribel Santos, placing them in overlapping operational roles without formal documentation explaining why. The nurses were interviewed separately after the surgery. Lena described moments during the operation where instructions seemed to arrive indirectly, sometimes through unusual timing that did not align with standard communication flow. Maribel reported similar inconsistencies in how tasks were assigned in the recovery coordination process. Neither nurse initially connected these issues to anything beyond emergency chaos, but when their accounts were compared, patterns began to emerge. Hospital administrators started reconstructing the timeline of the entire procedure. Digital records showed that Dr. Keller had accessed scheduling systems multiple times before the surgery began, making adjustments that were not visible to other departments at team. Some entries appeared to override standard protocols, while others created overlapping assignments that should not have existed in a properly regulated system. As the review deepened, it became clear that the irregularities were not random. They formed a structured pattern tied to repeated access points linked to Dr. Keller's account. The investigation revealed that operational decisions during the surgery had been influenced by hidden modifications made long before the emergency began. The discovery shifted the focus of the case from medical error to systemic manipulation. What initially appeared to be a complicated emergency procedure was now being reevaluated as a controlled environment shaped by unauthorized interference. The hospital leadership recognized that the situation extended beyond a single surgery and pointed toward a deeper issue within internal access and trust. The internal investigation at St. Mark's Medical Center intensified after the surgery review. Repeated unauthorized access to hospital systems. Cybersecurity analysts were brought in to trace digital activity linked to Dr. Adrian Keller's account. What they discovered confirmed that the irregularities were not accidental or limited to a single procedure. Instead, they formed a long-term pattern of controlled adjustments made over several months. His login records showed repeated access to staff scheduling platforms outside normal working hours. These sessions were often brief but highly targeted. Shift assignments for the intensive care unit and surgical recovery ward had been altered in ways that created overlapping responsibilities between specific staff members, including Lena Cruz and Maribel Santos. These changes were not logged through official approval channels, indicating deliberate bypassing of hospital protocol. As the data was reconstructed, a hidden structure became visible. Dr. Keller had been quietly reshaping parts of the hospital workflow to align with high personal interactions. The system revealed coordinated timing adjustments that kept certain staff members within proximity during specific shifts while preventing others from detecting the overlap. This manipulation had remained unnoticed because it blended into the constant unpredictability of hospital emergencies. Once the findings were confirmed, hospital leadership moved quickly. Dr. Keller was suspended from all surgical duties pending full disciplinary and legal review. His access to hospital systems was immediately revoked. Security escorted him out of the surgical department without incident, but the atmosphere inside the hospital changed instantly. Staff members who had once trusted his leadership now reevaluated past events under a completely different light. Lena Cruz and Maribel Santos were informed separately about the investigation's conclusions. Both nurses experienced shock as they learned how their schedules and assignments had been manipulated without their knowledge. E.g., the realization that their professional paths had been shaped through hidden interference caused deep emotional and professional distress. Trust within the department was severely affected, and counseling support was arranged for affected staff. Despite the disruption, the emergency surgery case itself ended with a successful outcome. The patient survived after hours of stabilization and intensive care. However, the success of the procedure stood in contrast to the collapse of trust within the hospital system. In the weeks that followed, St. Mark's Medical Center implemented stricter digital security measures and revised its scheduling authorization process. Dr. Keller's case became a permanent internal reference for systemic vulnerability. What began as a life-saving operation ultimately exposed a hidden breakdown in oversight, revealing how one individual's concealed actions had quietly influenced the structure of an entire medical department.